Hello students, welcome to GDC online classes. In this session, we are going to discuss regarding the excretion. So nothing but it is one of the parameter of the pharmacokinetic like absorption, distribution, metabolism, and finally it is the excretion and generally elimination of the drugs. So drug absorption is important for movement of a drug from the site of administration to the systemic circulation, and drug distribution from the systemic circulation to reach the target organ. And after completion of a drug molecule action, it should have reached the liver for the metabolism or biotransformation of drug. And after inactivation or after conversion of a drug into pure polar form, that is ready to eliminate through the urine, and here it is the excretion. So let's go into session in detail. So what is this excretion and what is the importance of this excretion and what are the different methods involved in the drug excretion. So let's start here. Excretion is a irreversible transport procedure which prototype or parent drug or other metabolic products excreted through the excretory organs or the secretion organ. So simply the process is an irreversible process. So simply once the substance is going outside through the urine or any other route, it is not coming back into the body. So simply it is a irreversible process. So simply it is a irreversible process. And further continuation, hydrophilic compounds can easily excreted. So any substance want to go for excretion, it should be hydrophilic in nature, it should be ionized in nature, and it should be non-volatile in nature. And especially if a drug molecule should be excreted through the urine, it should have molecular weight around 300 to 500 daltons. Mostly it should having 300 daltons molecular weight. And as you know, the major route for excretion of drugs will be the kidney, and apart from that there is also a bile excretion, sweat and saliva, milk, as well as pulmonary route. So some of the drugs are excreted through these routes also, but majorly you know that kidney, more than around 99% of the substance or drug molecule excreted by using the kidney as a route of excretion. And this is the general structure of kidney I mentioned here, because kidney is responsible for the drug excretion. So regarding the drug excretion as well as anatomy and physiology of kidney, we will study regarding the mechanism of the filtration. Mechanism of the filtration, nothing but excretion. Here it is the excretion. So there are three processes are there: glomerular filtration, tubular reabsorption, tubular secretion. Tubular secretion. So first we will start with the glomerular filtration. Glomerular filtration. So what is glomerular filtration? The amount of the net amount of filtration happening for the minute. So how much amount of ultra waste is filtered per 1 minute of time. So here the normal glomerular filtration rate is 120 ml per minute. So glomerular capillaries have pores larger than the usual. So if you observe, so here it is a glomerulus, and to this capillaries, blood capillaries will be there. Through that blood capillaries, the ultrafiltrate is comes to the kidney. For example, from the heart, around 25% cardiac output is supplied to the kidney. So that 25% is ultrafiltrate that will be filtered by the three different processes like glomerular filtration, tubular reabsorption, tubular secretion. And in that ultrafiltrate, there is a drug substances as well as endogenous waste substance like urea, creatinine, like that. And kidney is responsible for excreting of all water soluble substance. So if a substance is, for example, any drug molecule to eliminate through the kidney, it should be water soluble. Where, so generally we know that our pharmaceutical drugs are lipid soluble in nature, they are lipophilic in nature, but after absorption, distribution, especially in the metabolism, after completion of a phase 2 conjugation reaction, the drug become fully inactive metabolite as well as full hydrophilic in nature. That hydrophilicity is important for drug elimination. Next, all non-protein bound drugs, lipid soluble or insoluble, presented to the glomerulus are filtered, especially non-protein bound drugs only eliminated, because protein bound drugs are having large molecular weights, they unable to undergo the filtration. For example, albumin. Albumin is one of the plasma protein involved in drug binding. So albumin is having 65,000 Daltons molecular weight. So albumin is not enter into the kidney, because through the kidney for excretion only drug molecule with 300 Daltons only eliminated. But here the albumin is one of the plasma protein that is 65,000 Daltons molecular weight, so it unable to pass through the kidney because of its large molecular weight. If the albumin is present in the urine, it is definitely a problem in the kidney. Next, glomerular filtration of drugs depends on their plasma protein binding as well as renal blood flow, and protein bound drugs are not filtered. I already give information to you. So the GFR of a drug will be dependent on the, if drug binding to the plasma protein, it is not filtered. If drug is not bind to plasma protein, it will be filtered. And if a drug molecule undergoes excretion, it should be hydrophilic as well as it should be ionized in the nature. So generally, even renal failure as well as aged persons also, the GFR will be determined. For example, if person having the renal failure problem, that will be definitely affected the rate of glomerular filtration rate, and also aged persons. So when age is increasing, the organ capacity decreases, so kidney filtration capacity decreases, and the glomerular filtration rate also decreases. So if you observe in the diagram also, so for example, here some of the substances, glucose, amino acids, sodium, water, and here, so what is the indication here? Some of the substances are reabsorbed or secreted, nothing but excreted at different parts of the kidney. For example, proximal columnar tubule, distal columnar tubule, loop of Ehrlich, collecting tubules, collecting ducts. So like that, at different parts, there is a different electrolytes or different substances are reabsorbed or excreted. Next, tubular reabsorption. So what is simply GFR? Glomerular filtration rate. The net amount of filtration per minute through the glomerular capillaries is known as glomerular filtration. So the exact value of GFR is 25 ml per minute. The average value is 120 to 130 ml per minute. So next, tubular reabsorption. So at the tubules, there is a reabsorption of drugs is taking. This tubular reabsorption is increasing half-life of drugs, and tubular reabsorption is because of lipophilicity of drug molecule. So after completion of metabolism, especially after completion of phase 2 conjugation reaction, the drug molecule should become hydrophilic in nature, but still some drug molecules are lipophilic in nature, that lipophilic molecules reabsorbing at the kidney tubules. So reabsorption increase the half-life of drugs. This may also chance of increasing the toxicity of the drug. So here, back diffusion of drugs around 99%. Lipid soluble drugs depends on pH of urine as well as their ionization. So here, drugs are reabsorbing into the blood. So from the kidney tubules, again they are reabsorbing into the blood. This is dependent on their urine pH as well as their ionization. Especially lipid soluble ionized drugs excreted as it is, for example, 𝘂𝙂𝙎𝑃𝑔, like gentamicin as well as tobramycin. So generally this 𝘂𝙂𝙎𝑃𝑔 category of drugs are hydrophilic in nature and they are ionized in nature. So this hydrophilic ionized nature of drugs, they eliminated unchanged, means the same as like that after completion of action they eliminate from or excreted from the body. Changes in urinary pH can change the excretion pattern of drugs. So fluctuations or changes in the urine pH will affect the excretion of elimination of drug. For example, weak bases ionize more or less reabsorbed in the acidic urine. So weak bases ionize more, they are less reabsorbed in the acidic urine. Next, weak acids ionized are less reabsorbed in alkaline urine. So the drugs which are weak acid, they are ionized in nature. That ionized drugs are less absorbed in the alkaline urine, that is the urine pH is basic. Why? Because if you observe here weak acids and bases, so acid base will be ionized. So if ionized are there, they are readily excreted through the urine. The drug molecule with unionized nature, it may be reabsorbed back. The drug molecule with lipophilic nature, it may be reabsorbed back, increasing the half-life of drug as well as toxicity of drug. But here ionized molecules are eliminating through the urine, nothing but excreted. So utilized clinically in salicylate and barbiturates poisoning as well as alkalization of urine, especially like this can be useful in the salicylic acid as well as barbiturate poisoning. For example, salicylic acid is nothing but it is a acid and barbiturates also acid. So to eliminate, if this salicylic acid or barbiturates dose become excess in the body, that poisoning can be eliminated. So that poisoning or that overdose can be countered by giving the weak base or strong base, because the salicylic acid barbiturates are acidic in nature. If you give a strong base, this base ionized with these substances and ionized molecules are readily eliminated through the urine. Ionized molecules are readily eliminated through the urine. Next, acidified urine. So through acidified urine, substance like atropine as well as morphine will be excreted. Okay, definitely the urine pH will affect the excretion pattern of drugs. Excretion pattern of drugs. So next, further continuation, active tubular reabsorption. Active tubular reabsorption. Substances which are essential for energy conservation of body. So here some of the reabsorption involving the reabsorption of molecules or substances. In this active tubular reabsorption, some of the substances are actively reabsorbed with help of energy. So that substances are essential for the body, especially essential for the body conservation of energy. Examples like glucose, electrolytes, amino acids, water, vitamins, oxopurine, lithium, uric acid, as well as fluorides. The substance like this actively reabsorbed into the blood from the kidney. In some cases, this active tubular reabsorption is inhibited by exogenous substance like drugs. So in some cases, the drugs which we are taking from outside of the body, sometimes these drugs may inhibit this active tubular reabsorption. So that drugs like sulfenperazine, probenecid, both are gout drugs, and aspirin at high doses inhibit active tubular reabsorption of uric acid, and which helps in the gout treatment. So especially if in the body if there is a gout, so what it will doing, aspirin at high doses inhibits active tubular reabsorption. So inhibition of active tubular reabsorption of uric acid benefit to our body. Why? Because if it is not reabsorbing, so no problem, because uric acid, excess accumulation of uric acid in the joints of the body may develop gout. Next, passive tubular reabsorption means here it is a passive mechanism, no need of the, so it does not require the energy. So mechanism is passive diffusion. Highly lipophilic substances rapidly and extensively reabsorbed into the collecting duct. So in case of active tubular reabsorption, there is no matter of lipophilicity or hydrophilicity. So the substances which are essential to the body actively reabsorbed. But here passive tubular reabsorption, mostly highly lipophilic substance only reabsorbed. Polar drugs which are readily eliminated through the urine. So in the passive tubular reabsorption, highly lipophilic substance only can be easily reabsorbed, but polar drugs are easily excreted. Examples like aminoglycosides as well as digoxin, which are polar substances, can readily excreted through the urine. Next, tubular secretion. After after glomerular filtration, after reabsorption, next is a tubular secretion. So tubular secretion means here substances are secreted into the urine for excretion. So it is the energy dependent active transport reduces the free concentration of drug. Furthermore, drug dissociated from the plasma binding, again more secretion. Protein binding is a facilitator for excretion for some drugs. Okay, so here what is there? Tubular secretion. Tubular secretion reduce the free concentration of drug in the plasma, and this tubular secretion also make a drug dissociate from the plasma protein binding. If a drug is dissociated from the plasma protein binding, it is freely present in the plasma. That freely presented drug is available for the excretion. So here for the tubular secretion, there are different transporters are there. The major transporters like organic anion transport, and one of the major is again along with organic acid transport is organic base, nothing but organic cation transporter. Organic acid transport or organic anion transport, organic base transport or organic cation transport. Next, bidirectional transport, that is blood versus tubular fluid. So bidirectional, so it is a bidirectional, so sometimes to the blood, sometimes to the tubular fluid, and utilized clinically. So this tubular secretion also having the excellent clinical application. For example, penicillin versus probenecid versus uric acid, especially in the salicylates. For example, penicillin plus probenecid. So here if you observe, penicillin plus probenecid combination is a useful combination regarding the treatment of gonorrhea or syphilis, like sexually transmitted disease. But here penicillin probenecid compete with the same organic anion transporter. So because of this competition, probenecid is actively secreted into the urine for excretion, but penicillin is again reabsorbed into the blood. So this reabsorbed penicillin effectively helps in the treatment of gonorrhea or syphilis. And forget this combination, probenecid was salicylate, nothing but uric acid. So remember, penicillin was probenecid was intentional combination into the body. It helps in the treatment of syphilis as well as gonorrhea, a sexual transmitted disease. Because here in this combination of penicillin plus probenecid eliminating through the urine as a excretory product, but penicillin G is again reabsorbing. So this increase the half-life of penicillin G, and that will helps in the treatment of syphilis as well as gonorrhea, like sexually transmitted disease. Next, quinidine decreases renal and bile clearance of digoxin by inhibiting efflux carrier paraglycoprotein. So quinidine decreasing renal as well as biliary clearance of digoxin by inhibiting the efflux carrier protein, that is paraglycoprotein. So paraglycoprotein causes efflux of drugs from the cells. Okay, so but this efflux of digoxin can be decreases, or excretion of digoxin can be decreased by quinidine. Quinidine is an antiarrhythmic drug, and digoxin for generally for treatment of congestive heart failure. And next, further continuation, acidic urine. Alkaline drugs eliminated, acid drugs are reabsorbed. Because acid become unionized, acid base become ionized. That's why if the urine pH is acidic in nature, that is a good for excretion of the basic drugs. Next, alkaline urine. So alkaline means basic. That basic urine eliminate the acidic drugs, and alkaline drugs are absorbed because alkaline repel with each other, become unionized. Acid base become ionized and leads to ionized molecules are eliminated through the eliminate through the urine as a excretory product. So acidic urine eliminate the basic drugs, and basic urine or alkaline urine eliminate the acidic drugs. For example, here it is the pH 1 non-ionized, and at pH 12 it will be the ionized. And generally more drugs in the non-ionized form, is a drug readily absorbed from the intestine. So this is also interlinked with the intestine. Generally our pharmaceutical drugs, the drugs what we are taking, our pharmaceutical drugs are generally weak acids and weak bases. Because of weak acids and weak bases, they having good absorption. If the drugs are strong acids and strong bases, they may be ionized. So ionized molecules are having the poor absorption. Next, kinetics of elimination. So kinetics of elimination also very important concept. So first in that clearance. First in that is the clearance. So what is the clearance? Regarding the clearance of a drug is the volume of plasma from which drug is completely removed in unit time. So unit time nothing but in the particular term, the clearance of a drug is volume of plasma of drug which is completely removed in unit time from the body, especially from the plasma. So next, what is the renal clearance? So that is a simple definition of a clearance. Next is renal clearance. It is calculated from plasma or blood concentration, the urinary concentration, and the rate of flow of urine by the equation, that is renal clearance, and that is CuFU by Cp. Cp means plasma or blood concentration. Cu means urinary concentration. Okay. Next, clearance by the specific organ. For example, liver, the clearance of drug can be from the liver. The clearance of drug can be calculated by that is liver clearance equal to Q into X, that is C in minus QX C out by C in. So what is the Q? Blood flow for unit time, that is rate of blood flow. C in, concentration of drug in the inflowing blood. C out, concentration of drug in the outflowing blood. So this is a clearance by specific organ. So for example, the blood coming out of the organ, that is C out. Blood going into the organ, that is C in. Okay, that is C in. So this is simply clearance by the specific organ. So that is a simple formula for calculation of a clearance by the specific organ. And next, some of the important terminology like first order kinetics. So the rate of elimination is directly proportional to rate of administration, nothing but drug concentration. The clearance is remaining constant. The clearance will be the constant. So constant fraction of drug is eliminated per unit time. So mostly the amount of drug you are taking into the body will go for the excretion or elimination. That is first order kinetics. But when coming to the zero order kinetics, these are linear in nature. The rate of elimination remains constant irrespective of the drug concentration. The rate of elimination remains constant irrespective of its drug concentration. So clearance decreases with the increasing concentration. Examples like alcohol, theophylline, tolbutamide. So generally what is the point here? Clearance decreases by increasing the concentration or increasing the administration of drug. So initial dose, the drug you are giving, it showing the action, it going excretion. But when slowly the dose is increasing, so the drug metabolism will saturated and drug excretion decreasing, drug accumulation in the body increasing and increase the toxicity. That is a problem with zero order kinetics. So some of the examples like alcohol, theophylline, 𝘿𝙂𝙎 follows the zero order kinetics. Next, what is plasma half-life? What is plasma half-life? Defined as time taken for its plasma concentration to be reduced to half of its original value. This is a two phases, rapid declining and slow declining. So plasma half-life nothing but time taken for a plasma concentration nothing but drug to be reduced to half of its original volume. So generally it is in two phases. One is rapid declining and one is the slow declining. The general formula is half-life equal to ln by 2, ln2 by k. That is here ln2 is natural logarithm of 2, that is 0.693 is the value, and k is a elimination rate constant equal to Cl by V. V equal to dose of IV by C. V equal to dose of IV by C. Half-life equal to simple formula 0.693 into V by Cl. So this is a formula for to calculate the half-life of drugs. So half-life of drugs can easily calculate by using this formula. 0.693 by will 0.693 the value will be the constant and that into V by the Cl. Next, target level strategy. So what is a target level strategy? Especially low safety margin drugs maintained at certain concentration within the therapeutic range. Drugs like anticonvulsants, antidepressants, lithium, theophylline. So theophylline is a generally CNS stimulant as well as a relaxant on the bronchus mucosa. Lithium in the form of lithium carbonate for treatment of mania, and antidepressant for the depression treatment, and anticonvulsant for the epilepsy treatment. Here target level strategy. So the target level strategy means so to the target there we should follow some strategy, especially with some of the drugs. Why? Because the drugs what I mentioned here at initial doses they shows good biological action as well as pharmacological profile, but when dose is increasing they produce as side effects more than the beneficial pharmacological effect. They produce as side effect. That's why maintaining the strategy level is important to target organs, especially with these drugs. And generally like these drugs are known as narrow therapeutic index drug. So initially these drugs shows good pharmacological action, but when dose increasing the side effect profile of these drugs increases, known as narrow therapeutic index drug. So good therapeutic index means the drug having more beneficial effects than the side effects. Narrow therapeutic index means the drug may shows more side effects than beneficial effects when dose is increasing continuously. Next, further continuation, drugs with the short half-life 2 to 3 hours, drugs are administered at conventional intervals, that is 6 to 12 hours. Fluctuations are therapeutically acceptable. So especially the drugs with the short half-life around 2 to 3 hours, they administered at intervals of 6 to 12 hours. And long-acting drugs. So long-acting drugs are by loading dose. The loading dose is single dose or repeated dose in quick succession to attain target concentration quickly. Next, maintaining dose. Dose to be repeated at specific intervals. The simple is the dose should be maintained. For maintaining that dose constantly in the plasma or in the some of the organs to maintain their activity, the dose will given repeatedly. So I gave dose now and after 3 hours I will give again, like that at a different intervals. At a different intervals, drug administration for the maintaining dose, maintaining the sustained level, sustained concentration. And what is the need to monitoring of the plasma concentration? So after administration of a drug, we have to monitor the plasma concentration in the patient blood or circulatory volume. Why? So there should be a monitoring. Why? Because this monitoring useful in narrow safety margin drugs, nothing but drugs with narrow therapeutic index. What is the meaning of narrow therapeutic index? The drug shows more side effects than the beneficial effects. So examples like digoxin, anticonvulsant, antiarrhythmic, 𝘂𝙀𝙎𝙀𝙍, etc. For these drugs, plasma drug concentration monitoring is essential, and especially large individual variation. So drugs like lithium as well as antidepressant. So this drug shows different actions in the, maybe the action will be variated in the different persons. So in me they are showing different like manner of action, in you they show different like manner of action. So there is a chances of variation. So for that purpose also plasma drug monitoring is essential. And also in case of renal failure cases as well as poisoning cases, so kidney failure, so during kidney failure the drugs are not excreted easily, then we have to go for monitoring the drug concentration. Without monitoring drug concentration, again you administer the drug, there is a chances of toxicity. Why? Because already kidney is not performing well regarding excretion of drugs. So if you continuously giving the drug is not excreted, it is accumulated in the body and generates the side effects. And in case of poisoning cases also, monitoring is very essential. Monitoring is very essential. And this plasma drug monitoring is not essential or useful in the response measurable drugs like antihypertensive diuretics, means how much response it is showing. And drugs activated in the body like levodopa. So levodopa is a prodrug, converts to dopamine for treatment of Parkinsonism. And some of the drugs like hit and run drugs like reserpine as well as MAO inhibitors, monoamino oxidase inhibitor. As you know, reserpine is a natural alkaloid, and in initial days or olden days, reserpine used as a antihypertensive. Nowadays it is not using because of depression as a major side effect. So what is the meaning of hit and run drugs? Say simply they hit the receptor and they dissociate from the receptor. Next, irreversible acting drugs like organophosphorus compounds like malathion, parathion, 𝘂𝙀𝙎𝑃ℎ𝑎DE. These are indirectly acting cholinomimetics or acetylcholine agonist. And prolongation of drug action. Prolongation of drug action. Why drug action will be prolonged? By prolonging absorption from the site of action, that is by oral as well as parenteral. So how you can prolong a drug action? So by prolonging absorption, if you prolonging the absorption, especially by oral or parenteral routes, by increasing the plasma protein binding. If drug having more affinity, drug is binding more time to the plasma protein, its action will be prolonged in the body. By retarding drug metabolism, if drug is not metabolized, if drug is not available for the metabolism, drug half-life increases. By retarding the renal excretion, so some of the drugs are, especially highly lipophilic drugs, are not available for the excretion, because if a drug molecule want to be excreted, it should be highly polar in nature. The polar molecules are readily eliminated through the body, So this is regarding the drug excretion, drug elimination. This is very important for decreasing the drug toxicity. If there is no drug excretion, if kidney is not working properly, the drugs accumulated in the body, they generate the side effects or toxic effects. So drug excretion is one of the parameter in the pharmacokinetics. So pharmacokinetic is what body does to the drug, how body affecting the drug absorption, affecting the drug distribution, affecting the drug metabolism, drug elimination. So excretion is a reversible process movement of substances from the internal environment to the external environment, that is out of the body. So there are different route of administration through the kidney, through the bile, through the sweat, through the milk, through the pulmonary. And for the excretion, mainly three process: glomerular filtration, tubular reabsorption, tubular secretion. Glomerular filtration, the net amount of filter the substance or the blood filtering per unit time. The exact value 125 ml per minute is the GFR rate. The average is 120 to 130 ml per minute. So this glomerular filtration rate, this GFR can be estimated by using if GFR is going properly or not, GFR is efficient or not, by can be done by can be know by using endogenous as well as exogenous marker. The exogenous marker for kidney function, to determine kidney function, nothing but to determine GFR, inulin. Inulin is a polymer of fructose. So for determination of rate of GFR is proper or not, kidney functioning proper or not, the endogenous markers like urea creatinine, because urea creatinine 100% should be excreted. If they are still present in the blood, there is a problem in the kidney function. And exogenous markers like inulin. Inulin is a fructose, polymer of fructose. So the exogenous marker to determine glomerular filtration rate is inulin. The endogenous marker is urea as well as creatinine. So after that we discussed regarding glomerular filtration rate, tubular reabsorption, active tubular reabsorption, passive tubular reabsorption, tubular secretion, and some of the important points regarding, so based on the pH of urine, which drugs are eliminated, and kinetics of elimination, and first order, zero order kinetics, plasma half-life, and some of the important points in the excretion, that is pharmacokinetic parameter excretion. So this is our session, and in next session we will come up with another topic. Okay, thank you.